Okay, so good morning everyone. Today we will continue with our presentation on the science of the brain, part 6. We finished 5 parts and I don't know how many we will have, but not a lot. Okay, so what's this sign? What does it called? No, this is not a molar tooth sign. Mickey Mouse or face of a giant panda sign or panda midbrain sign. What does it indicate? What's the differential? Wilson disease. What else? Leigh disease. Excellent, good. I like it. So this is a face of a giant panda or panda midbrain or Mickey Mouse sign, whatever you like. An axial T2 MR of the midbrain shows high signal throughout the tegmentum, sparing the radionuclei, periaqueductal gray matter. Low signal is seen in the substantia nigra and cerebellar. Just a second. And cerebellar peduncles. So the differential diagnosis will be either Wilson disease, Leigh disease, or glutaric aciduria type 1. Wilson disease, as all of you know, it's an autosomal recessive disorder, interferes with normal copper metabolism, resulting in pathologic accumulation of copper and other heavy metals in the central nervous system, liver, kidney, and heart. On the T2-weighted MR, there is what's called the face of a giant panda, referring to abnormal high signal in the midbrain tegmentum. You can see here this abnormal high signal in the tegmentum of the midbrain, with a preserved normal signal of the radionuclei, the eyes, okay, of the panda, and periaqueductal gray matter. This is the nose of the panda. This is the periaqueductal gray matter preserved, and the radionuclei preserved, and the tegmentum is hyperintense. Okay, diffuse symmetric T2 hyperintensity in the subcortical white matter internal and external capsule, what's called bright colostrum sign. Also in the basal ganglia thalami can also be seen through and thought to represent edema or gliosis. The differential diagnosis includes other metabolic disorders such as Leigh disease and glutaric aciduria type 1. Okay, nice. What's this sign? Again, has something to be related with the panda. No, not legs. This is a miniature panda sign, or panda cub, baby panda. Okay, miniature panda. Does anyone knows what does it indicate? Again, it's Wilson disease. Okay, this is the baby panda, the miniature panda, the cub. You can see hypointensity of the central tegmentum tracts, the here and here, okay, and brachial conjunctivum. The fourth ventricle appears normally hyperintense with a central flow void. Okay, you can see the flow void within the fourth ventricle. This is what's called the face of the miniature panda, which refers to abnormal high signal within the pontine tegmentum, normal signal in the cerebellar peduncles, and hypointensity of the medial longitudinal fasciculi, central tegmental tracts, and the superior cerebellar peduncles, and hyperintense fluid signal within the aqueduct of Sylvius and the fourth ventricle. So the nose and the mouth of the miniature panda is this, okay? The signal within the fourth ventricle, the flow voids. This sign is termed the double panda sign and virtually pathognomonic for Wilson disease. If you can see this sign, it's pathognomonic for Wilson disease, like the big panda and the small panda, something like that. Something like that. I don't know whether you can imagine it or not. Okay. Diffuse symmetric T2 hyperintensity in the subcortical white matter internal and external capsule. We said it is called the bright colostrum sign. The basal ganglia thalami can also be seen and thought to be represent, as we said, edema or gliosis. Okay. What's this? How do you describe this midbrain appearance? You can see this dark line here, telling you what to look for. No, No, this black line we put it. This is for demonstration. This one. What does it show you? This is what called sagging or swelling of the midbrain. Sagging, يعني شيء مرتخي. Let go, relaxed midbrain, indicating, as you said, intracranial hypotension. When hypotension, okay. So you can see there is a distended midbrain. This bridge is sagging, يعني شيء واقع, okay. So shows the a distended midbrain and inferior migration of the brainstem with the flattening of the pons against the clivus. The pituitary gland is also distended. You can see it here, indicating intracranial hypotension, which can be caused by idiopathic, degenerative, traumatic, and iatrogenic etiologies. Dural tear in the midbrain, dural tears in the brain or spine cause continuous loss of fluid, resulting in CSF hypovolemia. The deep cerebral structures and the brainstem become swollen, what's called the fat midbrain. Reflecting mild diffuse vasogenic edema, there is a flattening of the pons against the clivus, effacement of the prepontine and the interpeduncular cistern. The prepontine cistern, you can see it, it's small, it's effaced, it's narrow, it's compressed, whatever you like, okay? The entire brain migrates inferiorly with low-lying brainstem, cerebellar tonsils, third ventricle, optic chiasm, mammillary bodies, splenium. All of them will migrate inferiorly due to hypotension, due to decreased CSF volume. The patients may present with orthostatic headache, cranial neuropathies, nausea, vomiting, fatigue. There are a lot of different investigations to identify where is the leak, okay? Including, can anybody? Cysternography, radionuclear cystography is very good procedure. Also conventional CT or MRI myelography. Once identified, the leak can be repaired by what's called epidural blood patch. Do you know what's epidural blood patch? They just take the blood of the patient, centrifuge, take the clot, inject it. At the site of the leak will occlude the leak. Okay? Also percutaneous fibrin glue injection or surgery. Good. Now, what's this? How do you describe the... Sorry? No. What? Ring enhancing, thick walled, ring enhancing, heterogeneous, little bit lesion, showing what's called feathery or soap bubble or Swiss cheese appearance. Okay? What does this indicate? No. What do you think this kind of appearance indicate? Anyway, طبعا there is a differential diagnosis, of course, but it is, if you can appreciate that this is the feathery or the soap bubble appearance of a ring enhancing lesion in the deep part of the white matter, this is highly indicative of radiation necrosis. Okay, keep that in mind. It indicates radiation necrosis. So, there is this is an axial contrast T1 weighted MR image showing ring enhancing lesion with in the right coronal radiata with ill-defined peripheral enhancement, indicating radiation necrosis. So there is in radiation necrosis, you always keep in mind there is a characteristic soap bubble or Swiss cheese enhancement, reflecting the internal necrosis. The enhancing margin gradually blend with the surrounding brain, producing of the feathery or the spreading wave front appearance. The margin is not like just enhancing, it's enhancing and blends with the surrounding brain, gradually fades away, okay? In the setting of treated tumor, especially high-grade glioma, local recurrence and radiation necrosis are difficult to distinguish. So, what imaging studies can we do to distinguish? It is recurrence or radiation necrosis? Yalla. First, CT MR perfusion. The perfusion will be increased in recurrence, decreased in radiation necrosis. Okay? Also, MR diffusion, diffusion العادي. Okay? Which is in recurrence will be what? reduced diffusion in recurrence, restricted diffusion, and normal or increased in necrosis. Good. What else? MR spectroscopy. What will you see in just a second, حتى لا نخربط. In recurrence, what will happen? Increased choline to creatinine and choline to NAA ratio in recurrence. While in necrosis, decreased metabolites, lactate peak. Excellent. Okay. What else? SPECT, thallium 201 single photon emission tomography, SPECT, which will show increased uptake in recurrence, decrease in radiation necrosis. Also PET, 18 FDG PET, which will be increased metabolism in recurrence and decrease in necrosis. So all these are investigations to differentiate, and it is difficult to differentiate. After all of that, it's still difficult to differentiate. We may still, in some cases, after all of that, biopsy may be needed. Okay? Good. So, this is an easy one. Diagnosis: parenchymal laceration and intraparenchymal hemorrhage, and due to contusion, of course. So, what does the appearance called? This is what's called mottled, flecked, or salt and pepper appearance. Okay, of the brain, not of the calvarium. That's a whole different story. We are talking about the brain. Okay, this is axial CT, shows mixed edema and hemorrhage in the bilateral inferior frontal and right anterior temporal lobes. Diagnostic of hemorrhagic contusions. Keep in mind that the cerebral contusions are caused by low velocity direct head trauma. The coup injury will occur at the site of the impact, while the counter coup will occur where? Opposite. Okay? Confluent areas of edema in the inferior frontal and anterior temporal lobes are the result of impaction against the cribriform plate and the sphenoid wings, the coup. Okay? The frontal will impact against the calvarium, against the ethmoid, against the temporal bone, resulting in the injury. Okay? Petechial hemorrhage reflects traumatic shearing of the small vessels and may be seen at the gray-white junction, deep gray matter, brainstem, periventricular regions. On the CT, the combination of hypodense edema and hyperdense hemorrhage produce what's called the salt and pepper appearance. The edema is hypo, the hemorrhage is hyper, mixed together, giving the salt and pepper appearance. Small, simple contusions may normalize on follow-up imaging, whereas large and severe contusions progress to encephalomalacia. Late complications include attention deficit, emotional abnormalities, and memory deficits. This appearance can cause. Okay? Good. What do we have here? This is a very characteristic appearance for a very characteristic disease. Anybody? Diagnosis or differential? Cryptococcosis, exactly. Cryptococcosis is commonly presented with this gelatinous pseudocyst or soap bubble appearance. It's like prominent vercabrobin spaces, dilated perivascular spaces, but it is not dilated due to the usual aging or atrophy or whatever. It's dilated due to cysts within the perivascular spaces, the cryptococcosis cysts surrounding the vessels, dilating the spaces. Okay, this is a common board case. It happens a lot. You can see a T2 weighted MR shows cluster cystic lesions in the bilateral basal ganglia and cerebellar dentate nuclei, which is diagnostic of the cryptococcosis. This is the gelatinous pseudocyst you buy to the kids. It's looks like cryptococcosis. You can see these are the dilated perivascular spaces in the basal ganglia. And so the Cryptococcus neoformans is an encapsulated fungus found in the soil, usually from birds' excreta. It is the most common fungal infection in the CNS and the third most common in AIDS patients, okay, or immunocompromised individuals in general. Usually spread hematogenously from the lungs to the central nervous system, resulting in CNS cryptococcosis, sometimes called torolosis. Okay, 3 patterns have been identified: the parenchymal granulomas, gelatinous pseudocysts, and meningitis in the brain. Either gelatinous pseudocysts or meningitis. Huh? Wake up. Okay, good. Okay, so these are the gelatinous pseudocysts presenting dilated perivascular or Verka-Rubin spaces filled with inflammatory cells, mucoid material produced by the fungal capsule. It dilates the perivascular spaces. Okay, also can be seen the predominant areas. You can see that is the basal ganglia, the thalami, midbrain, cerebellum, periventricular regions, which appears hyperintense on T2 and variable on T1, depending on the mucin content of the cyst. The degree of immunocompetency will determine the amount of edema and enhancement. Early treatment with IV antifungal is crucial to minimize the morbidity and the mortality. Okay, so if according to the amount of immunocompetency, the edema will differ. Okay, the much more competent, the increased immunity will increase edema, and vice versa. Okay, so what do we have here? There is no signs of infarction. If you see here, it's not subarachnoid. This is an MRI rather than CT, so subarachnoid would be little bit difficult to see on these cases. You can see there is leptomeningeal increased signal intensity. Okay, this is T1. Okay, T1 image. So there is leptomeningeal increased T1 signal intensity, suggesting what's called gyriform or leptomeningeal enhancement or serpentine-like enhancement. So this has a differential diagnosis of what? Meningitis in general. Okay, increased leptomeningeal enhancement. This is the serpentine-like. Serpent means like a snake. So you can see this coronal contrast enhanced T1 showing leptomeningeal enhancement in the right parietal lobe, which suggests either infectious or inflammatory meningitis, vascular conditions, and leptomeningeal carcinomatosis. So the enhancement of the arachnoid and the pia mater reflects breakdown of the blood-brain barrier, subsequent contrast leak from the vessel into the cerebrospinal fluid. The common etiology will include either infectious, inflammatory meningitis, vascular conditions, leptomeningeal carcinomatosis, pyogenic meningitis, bacterial meningitis, viral meningitis. Will demonstrate smooth linear leptomeningeal enhancement. Fungal meningitis, tuberculous, and other granulomatous meningitis demonstrates more nodular enhancement, with a prediction for the basal cister, like sarcoidosis, for example. It is nodular, it's more in favor of fungal or tuberculous or other granulomatous. If it is smooth, it's more in favor of viral or bacterial. Okay? Vascular etiology includes acutely reperfused or subacute arterial infarctions, posterior reversible leukoencephalopathy, the PRES, vasculitis, and vasodilatation associated with migraine or seizure. Typically, the subjacent cortex is also involved in these conditions. If the gist cortex is not involved, it's against. Okay? Metastasis from CNS primaries, like also breast, lung, melanoma, and lymphoma, can diffusely involve the meninges. Inflammation secondary to prior surgery or subarachnoid hemorrhage can occasionally produce leptomeningeal enhancement. Okay, so when you see this appearance in a post-contrast T1 weighted image, you keep in mind there is something seriously wrong with the leptomeninges, either meningitis or carcinomatosis. And according to the side, the related findings of the brain and the history will guide us to the rest of the possible differential diagnosis. Okay, good. So that's a very uncommonly seen one, and I don't think any of us seen it before and I don't think we will see it after, but we need to know about it. This is what's called the hockey stick or the pulvinar appearance. Okay, so what do you think? Creutzfeldt-Jakob syndrome. Yes, exactly. It's the mad cow disease. There is symmetric increased signal in the dorsomedial and pulvinar nuclei of both thalami. This increased signal intensity here and here is suggestive of Creutzfeldt-Jakob disease, which is a rapidly progressing fatal dementia caused by what? Prions. What's called prions. Prions, it's a protein, okay, that can replicate itself, okay? On the MRI, there is rapidly progressive signal abnormality of the basal ganglia, thalami, and cerebral cortex with cerebellic T2 hyperintensity and reduced diffusion can be seen in the pulvinar and the dorsomedial nuclei of the thalamus, what's called the hockey stick appearance that you can see here. You can see this hockey stick here, just looks like that. This is the hockey stick, okay? Also in the caudate head, putamina, globi pallidi, insula, cingulate cortex, periaqueductal gray matter. Occasionally also intrinsic T1 shortening, and T1 hyperintensity may be present, which is thought to represent deposition of prion proteins. In the late stage, there is a massive loss of the brain tissue that produces what's called the spongiform or Swiss cheese appearance. Sir, like Swiss cheese, you know, this filled of holes, the cheese. Okay. This is an easy one. Hummingbird sign, or what's called the penguin sign. You can see this hummingbird, okay, indicating progressive supranuclear palsy. Okay, this is the hummingbird. So this MR image shows brain atrophy of the midbrain with concave superior margin and deep interpedicular fossa. The pons and medulla are normal in size. This is suggestive of progressive supranuclear palsy, which is an adult onset neurodegenerative disorder, the most common cause of Parkinsonism following Parkinson's disease. First is Parkinson's disease, then is progressive supranuclear palsy. The symptoms includes dementia, postural instability, vertical supranuclear gaze palsy, with selective atrophy of the midbrain, tectum, tegmentum, flattened or concave margins, and a deep interpedicular fossa. On the sagittal images, you can see the hummingbird sign referring to the midbrain atrophy with normal pons and medulla. On axial images, the Mickey Mouse or the morning glory sign is produced by midbrain atrophy with preserved cerebral peduncles. Focal hypometabolism on the PET, hypometabolism will decrease metabolism on the PET, it's due to atrophy, gives rise to what's called the pimple sign. Findings may be difficult to distinguish from age-related volume loss and other dementia disorders. Like all neurodegenerative disorder, the clinical is very important for narrowing the differential diagnosis. Okay? Now, another easy case. What's the appearance? This is what's called the hyperdense fox or hyperdense tentorium. Okay? And it indicates what? Subdural hematoma. Excellent. So, or subdural hemorrhage or hematoma. CT shows left hollow hemicephalic subdural hematoma extending superiorly along the falx cerebri and inferiorly along the tentorium cerebelli. Okay? Indicating subdural hematoma or subdural hemorrhage, which are bleeds from the dura mater and between the dura mater and subarachnoid mater, which is caused by shearing stress on the bridging veins due to rotational and or linear forces, resulting in low pressure bleeds. So the subdural is low pressure, while the epidural, because it's venous in nature, while the epidural is high pressure because it's arterial in nature. So the epidural are more severe or more serious than the subdural hemorrhages. In the very young and the elderly, also in alcoholic patients, the presence of enlarged subdural space can predispose to the subdural hemorrhage with minimal head trauma. Symptoms include gradually increasing headache, confusion, At the imaging, the subdural hemorrhage is typically crescentic in appearance, outlining the cerebral convexity and tracking along the dural reflections, the falx cerebri and tentorium cerebelli. A small subdural hemorrhage may represent as a subtle hyperdense thickening of the falx or tentorium, which can be easily missed. So you need to be careful here. The differential diagnosis for hyperdensity in the subdural space include infectious, like subdural hematoma, inflammatory, and neoplastic etiologies, which can readily be distinguished on the contrast enhanced images. Okay? Good job. So, what do we have here? This is again of one of the neurodegenerative disorders. This is what's called the hyperintense REM or putaminal hyperintensity or slit-like appearance. Okay? Suggesting of multiple system atrophy, the Parkinsonian subtype. Okay? It's a neurodegenerative disorder showing this T2 hypointense signal, linear hyperintensity along the lateral putaminal margins. Okay? You can see this, the lateral putaminal margins, there is a T2 hyperintensity. The susceptibility weighted shows putaminal atrophy with T2 hypointensity. Again, the MSA is an adult onset neurodegenerative disease, like we said, which is characterized by Parkinsonism, autonomic failure, cerebellar ataxia, pyramidal signs. The Parkinsonian type shows selective atrophy and mineralization of the putamen with T2 hyperintense and T2 hyperintense signal. On the T2 weighted and the FLAIR MR, the putamina appear abnormally hypointense with a residual hyperintense REM. There is linearization of the lateral margin, producing what's called the slit-like appearance. You can see it obviously here. These findings can be difficult to distinguish from other age-related degenerative disorder, and like we said, history is very important to differentiate. Okay? So what do we have here? Again, neurodegenerative disorder. What's atrophy of temporal lobes? What's called knife blade or the edge appearance. Knife blade, شفرة السكين. Okay. This suggestive what? Frontotemporal degeneration. Okay. This appearance suggests of frontotemporal degeneration. This T2 weighted MR shows selective atrophy of the frontal and temporal lobes, enlargement of the Sylvian fissure, and there are sharp pointed gyri. Okay? Which this frontotemporal lobar degeneration, it's a spectrum of neurodegenerative disorder characterized by selective progressive atrophy of the temporal and frontal lobes. Up to 40% of cases are familial with autosomal dominant inheritance in about 20%. At imaging, there is characteristic enlargement of the Sylvian fissure, widening of the sulci, pointed knife edge gyri. Finding may be difficult to distinguish from age-related volume loss and other dementing disorders. Again, like in neurodegenerative disorder, correlation with the clinical is very important. You can see this is the knife blade, like here, due to the atrophy and the enlargement of the Sylvian fissure. Okay? Here, sorry, I think this is what's called the lamp wool sign, which is characteristic of primary CNS lymphoma. Okay, you can see multiple pulvinar and subependymal masses involving the left frontal horn, atrium, septum pellucidum, and splenium with patchy contrast enhancement. It's like هذا القوس الصغير lamp wool, sweet CNS lymphoma, so nice. Okay, which occurs in immunocompromised patients and immunocompetent individuals after their 5th decade. The most common type is non-Hodgkin B-cell lymphoma. Due to the tumor hypercellularity, the lesion will be on CT what? Hyperdense. It's hypercellular. On the T2, hypo. Okay. with reduced diffusion. In immunocompetent patients, lymphoma demonstrate mild patchy enhancement with what's called lamp wall appearance. So the lamp wall appearance is more in favor of immune competency. Lesions can be multifocal and involve the brain parenchyma, vessels, ependyma, and the meninges. Okay? Okay, we have time for a few more. What's this? It's a lenticular lesion. Okay, lenticular appearing lesion suggesting of epidural or extradural hematoma. Okay? There is a right temporal tip epidural hematoma suggesting of epidural hematoma. As we said, it's due to bleeds located where? Between the skull and the dura. So it's arterial in nature. It's more traumatic. Major trauma needs to be happen. Okay, usually there is skull fracture producing laceration of the meningeal arteries. Usually what artery? Middle meningeal, which is a branch of internal or external? External. So the middle meningeal artery, it's an external carotid artery branch. Okay? Less commonly, dural venous sinuses. Classically, the patient have a lucid interval followed by rapid loss of consciousness due to high pressure bleed beginning to compress intracranial structures. At the imaging, the extradural hematoma has a lenticular appearance that is constrained by the cranial sutures. It does not cross the sutures. Prompt surgical intervention is critical for minimizing morbidity and mortality. Okay? Yeah. So, sorry? مدى اسمه tonsillar herniation, low-lying tonsils, exactly. What's the differential diagnosis? يلا قولوا لنا. Carry 1 بعد intracranial hypotension بعد tonsillar ectopia. Keep that in mind, okay? You can see the cerebellar tonsils. This is the foramen magnum, and the cerebellar tonsils are herniated more than 5 millimeters. Some people say 3, some people say 5, some people say according to age. In general, more than 5 is definitely abnormal. Okay, 5 millimeter. So there is cerebellar tonsils extending below the foramen magnum. The differential diagnosis will be tonsillar ectopia, KRE1 malformation, intracranial hypotension, and tonsillar herniation for whatever reason. The cerebellar tonsils are normally located above the foramen magnum, may be at or slightly below this level. The ectopia, tonsillar ectopia, is a normal variant, which the tonsils are located within 5 mm of the foramen magnum, without other anatomic abnormalities. In KRE1, the tonsils will have a peg-like configuration and are displaced over 3 to 5 mm below the foramen magnum. There may be associated cervicomedullary kinking, obstruction of the CSF outflow, which can result in syringohydromyelia. In intracranial hypotension, what's called the CSF hypovolemia, there is downward sagging of the entire brain, including the tonsils. Associated finding includes venous engorgement, brainstem pituitary edema, like we saw in the previous case, okay? Also subdural effusion. Intracranial hypertension causes crowding of the intracranial structures, which in severe cases can lead to tonsillar herniation. Okay? شنو? Okay, I think we have time for one more, and then we will continue for the next session. I think will be the last in the size of the brain. We're having not much more, maybe 50 slides, something like that. Anyway, what's the sign? It's a very diagnostic of Mickey Mouse sign or the morning glory sign. Again, it is a diagnostic of progressive supranuclear palsy. You can see midbrain atrophy, concave lateral margins at the tegmentum, and the cerebral peduncles are normal in size. Again, as we said, it's the PSP, the progressive supranuclear palsy, is an autosomal dominant, it's an adult onset neurodegenerative disorder. Most common cause of Parkinsonism following Parkinson's disease, like we said. The clinically present as dementia, postural instability, vertical supranuclear gas palsy, selective atrophy of the midbrain, tegmentum, tectum, with flattened concave margins and a deep interpeduncular fossa. On the axial images, you'll see a Mickey Mouse or morning glory sign produced by midbrain atrophy, preserved cerebral peduncles. On the sagittal images, there is the hummingbird sign, refers to the midbrain atrophy with juxtaposed with normal pons and medulla. As we said, focal hypometabolism on the PET scan will produce the هسه قلنا قبل شوية شنو هي؟ بالبت hypometabolism will produce what sign? Pimple يعني بثرة بثور. Okay, sign. Again, we need clinical history. Clinical is very important for the diagnosis. Okay, so should we stop here? I think we should stop here and continue on the next week inshallah. Thank you.